Blog Talk Radio. Welcome to today's episode of mPatient Myeloma Radio, a show that connects patients with myeloma researchers. This series is in place to help you understand the need to join clinical trials. Today, less than 5% of myeloma patients participate in clinical trials, but if we participated, we could step up the pace at which researchers can find new therapies and a cure. It's in our best interest to join these trials. If you'd like to receive a weekly email about past and upcoming interviews on the show, you can subscribe to our mPatient Minute newsletter on the homepage, or you can follow us there on Facebook or Twitter. And please feel free to share these interviews with your myeloma friends. We have a new site called myelomacrowd.org. That's the first comprehensive site for myeloma. Please take time to explore some of these links. There are references to everything in the world of myeloma, and a list of who to follow on social media, news sources for myeloma, a growing online myeloma specialist directory, and current articles on myeloma topics. You can also contribute what you're learning by clicking on the Become a Contributor link. Now, we are exceptionally honored today to have with us Dr. Pieter Sonneveld of Erasmus Medical Center. Dr. Sonneveld is the head of the hematology department and is professor of hematology at the Erasmus University in Rotterdam in the Netherlands. At the Erasmus Medical Center, he is also head of the Multiple Myeloma Research Group, chairman of the Commission of Translocational Medicine, member of the Oncology Board, member of the Internal Hematology Oncology Integral Center, board member of Molecular Imaging, board member of the Committee on Laboratory Information Systems, member of the Biobank Committee, and coordinator of the Pearl Program for Leukemia. Outside of the region, he is very well known as the chairman of the Myeloma Working Party of HOVON, which is a foundation, member of the HOVON Executive Board and Treasurer, coordinator of the CTMM Program for Myeloma, coordinator for a population-based registry for hematologic malignancies. He's on the scientific advisory boards for the IMF, the MMRF, the Myeloma UK Foundation, and the UK Leukemia Research Fund. He is the chairman and founder of the European Myeloma Network and Consensus Group for Therapeutic Guidelines in Myeloma. He's a member of the scientific and executive board of the International Myeloma Working Group, chairman of the Scientific Working Group for Myeloma's European Hematology Association. He's on the editorial board of over 8 major publications, including Leukemia Research and the European Journal of Cancer and Clinical Oncology, and is associate editor of Hematologica. Unbelievably, I didn't mention everything he is doing or has done. Maybe you can first explain the HOVON Foundation and your founding of the European Myeloma Network, because I think that's just fascinating.
Okay, so the HOVON Foundation is a foundation in the Netherlands, Belgium, and Luxembourg, the so-called Benelux. And it was founded approximately 30 years ago in order to set up clinical trials in HemOnc. In the early years only in acute myeloid leukemia, and then later on also in other leukemias, myeloma, and malignant lymphomas. And currently it's the major cooperative network for performing clinical trials in the Benelux. A total of more than 135 trials have been initiated, and many of them already completed and published. And also in myeloma, multiple myeloma, we have been active in setting up prospective randomized phase 3 trials, primarily from, I think, somewhere around 1995 when we started with myeloma trials. But as you know, it is important with all the new agents coming to clinical trials that we can perform trials within a relatively short time period. And this is why we concluded that we needed a larger yearly accrual of patients for the trials. And the only way to accomplish that was by initiating a more European type of approach. And this is why we, with other people from Italy, Spain, Germany, and so on, we have initiated the European Myeloma Network. And this is a network of, let's say, the cooperative groups from the different countries. So GMEMA from Italy, the GMMG from Germany, the HOVON from Benelux, the Nordic Myeloma Study Group from the Scandinavian countries, and several other smaller countries like Austria, Switzerland, Greece, etc., that participate in one common myeloma network, a European network, and this is fairly successful, I would say, since in this setting we were able to set up a large prospective trial, the EMN02, with 1,500 patients, and that this trial just was completed in less than 3 years.
Wow.
So this is how we work now in Europe in order to accelerate the patient accrual for clinical trials and to be able to run several trials at the same time in the same patient group.
That's the goal of this whole series, is to help patients understand the importance of participating in clinical trials. So as this group is constructed and more researchers come together, how does clinical trial participation work in Europe? And how is that different from how it works in the United States? Because several researchers in the U.S. have noted how they're sort of envious of how you're able to construct the trials more quickly and recruit more quickly.
I think that in Europe there's probably a little bit more awareness of the relevance of clinical trials also among patients. And this is because we are used to working in smaller networks already. For example, my hospital is a university hospital in Rotterdam, in the Netherlands, and our region is approximately 4 million people with 20 hospitals. And from those 20 hospitals, patients are sent to the Erasmus University Hospital for reference, especially if they are young and have, for example, hem-onc disease like leukemia or multiple myeloma. And there's a constant inter-exchange of information between the local, the community hospitals and the university center in order to discuss whether patients are eligible for trials, whether they should be included, or whether they are better off when they just stay in the community hospital and get the standard treatment. And this has increased the awareness of trials and also the wish of patients to participate in trials, because they also know that they will have the newer drugs if they participate in the trial. And so for myeloma, for example, the transplant-eligible patient group, more than 80% of those are included in clinical trials. So
wow.
This is how it works.
That's stunning, because less than 5% of patients participate in myeloma clinical trials in the U.S.
Yes, but maybe that's also because in the U.S. Patients, they are diagnosed in private practice offices, and then they are not referred or discussed with a center. There's also maybe a financial aspect to that, and this is not present in Europe, at least not in the Netherlands and in the Scandinavian countries and Germany and so on.
Right. Well, can you explain also, you explained a little bit about the HOVON Foundation. When did that begin?
It started approximately 30 years ago in the early 80s, when the hematologists of the university hospitals came together in order to explore whether they could do something to improve the outcome of patients with acute myeloid leukemia, which was at that time very dismal. In some respects, it still is. So they started the foundation, HOVON, in order to create a platform for performing clinical trials, with also initiating a data center, trial monitoring, local and central data management, and all the things that you need to perform clinical trials. Financial office as well, and fundraising to pay for the clinical trials. And this has grown to, as I said, also myeloma and non-Hodgkin lymphoma and CLL, and the most common hem-onc diseases.
Does that contain a tissue bank also?
Yes, also tissue banking and a population-based registry. Both are parts of the HOVON trial organization. So there's central tissue banking, also central labs for correlative studies like gene expression profiling or SNP analysis, flow cytometry, and all this is centralized in one or two laboratories.
And does your data registry, that's just for the 3 countries, or does that expand throughout the European myeloma network as well?
Well, the population registry is only for the Netherlands at this time, but we know there are similar activities in Germany and in Italy, Czech Republic and the Scandinavian countries. And at this time we are busy in merging those clinical databases in order to be able to perform analysis. And this is, I think, almost realized now for multiple myeloma. And for leukemia, there's also activities in this field.
It just seems that would be very key to making decisions. And I know you're leading this effort internationally to ensure consistency. Maybe we do want to talk about that because I know that you are very key in leading the effort to establish this consistency for myeloma management guidelines, for consistent diagnostic testing and risk assessment. Can you talk a little bit about the progress that you've made in those areas?
Yes, of course. So in HOVON, we started to develop guidelines especially for myeloma and lymphoma, CLL, for both diagnostic approaches and treatment guidelines. And because we are living in Europe, often there are differences between countries, differences in reimbursement for novel agents, and also different treatment customs and approaches. We decided to develop guidelines, pan-European guidelines within the European Myeloma Network as well. And these guidelines, they have to be useful and they have to serve the different interests in the European countries, and also take into account the availability and accessibility of, for example, highbrow diagnostic procedures that are not so common yet in eastern part of Europe. So the guidelines of the European Myeloma Network address also the differences in availability of diagnostic procedures and also availability of drugs. So we are not only focusing on the best treatment, we are also focusing on available treatments and how choices should be made between those.
And has this expanded to other countries outside of Europe with these guidelines? Because I know everyone is looking at these guidelines.
Yeah, well, we are restricting our activities to Europe at the current time, although in some trials also the Australian group is participating, but in general it's only Europe at this time. But we know that, for example, that from the EHA, the European Hematology Association, there comes a lot of interest from the people in the Middle East to participate in these kinds of activities. And they are really looking at our guidelines as well, yes.
And what have you determined so far in guidelines and risk assessment and myeloma management? Do you want to go into a little more detail about what you've determined?
Well, one of the issues that we have paid attention to is whether bortezomib should be used in first-line treatment, because it was only approved in elderly, non-transplant eligible patients for first-line, and it was not approved for transplant-eligible patients for induction treatment. And so this is something that we explored, and we highly recommended to use bortezomib also in the younger transplant-eligible patients. And this was, in the end, I think, it was taken over by the EMA, and now it's standard treatment across Europe in all the different countries for younger patients. But this took about 3 or 4 years to get this accomplished, and it started with the guidelines. So by taking such a specific issue and really address it in a guideline, a pan-European guideline, we can also have some influence on the authorities and the agencies that are responsible for the reimbursement process. And
also for standard testing, I know there have been several researchers on the show in the U.S. that have talked about the need to standardize the FISH test. And I know a lot of work is being done in flow cytometry in Spain, and that, you know, I guess you get what you test for in FISH from what I've learned, and that not all the tests are standardized. So can you talk about diagnostics for a minute, about how that has been standardized, or what you're finding?
So our idea is that if we standardize tests in clinical trials. Usually they will also be adapted and those standards will be used for patients not included in clinical trials. So with the large pan-European trial that I just mentioned with 1,500 patients, we defined the number of FISH probes that we thought would be necessary to determine the risk group of a patient. And so we defined 5 probes, and this was used universally throughout the different European countries using the same probes for the same abnormalities. And what I understand, at least this is true for the Netherlands, Benelux, and also for the Scandinavian countries, is that in general practice, the same probes were adopted for use in patients not included in clinical trials. So this is true for diagnostics, but also for supportive care and other topics that are important. If we define those quite well in the context of clinical trials, practitioners will start to take those for use in the context of their general practice, also for patients not included in clinical trials.
And do you find that the guidelines that you're developing, that, like you're saying, the local oncologists will follow those protocols? Because there's a really wide variety in the United States about how myeloma is treated. So maybe we want to talk about that next, how you're able to increase consistency, I suppose, on the treatment, or what is the standard treatment for a European network?
So, as you know, we have developed international guidelines in the International Myeloma Working Group over the past years for a lot of different situations, but they do not always address typical European situations. So we have in the European Myeloma Network, we have also addressed other questions for which we would develop guidelines. For example, how should we determine the presence or absence of lytic lesions? In most European countries, it's not possible to use MRI in the diagnostic situation for any suspicion of lytic lesion. Many countries are still using conventional radiography. And what we have tried is to introduce in the guidelines the kind of order in which you can use the different diagnostic procedures. So if you have only X-ray available, what can you conclude from it and what can you not conclude? And then do you need to change to bone CT? Or what is the specific situation when you really have to go for MRI? I mean, just to be practical in the different countries and give people some kind of reference when they should use the different techniques and how they should interpret the data.
Well, I read a little bit about the UK and their MRI new technique that they were using, the whole body imaging, and wondered how that would become available both in Europe and in the United States. We've lived in a foreign country before, so I completely understand availability in some countries and not in others. How long do you think that will take to become more prevalent?
Well, that depends also on the financial reimbursement. In Europe, this is different from the US probably. You cannot always use the preferred technique because it will not be reimbursed. So as for the whole body MRI, many insurance companies do not reimburse this for multiple myeloma, since they think that with a bone CT you can have results that are sufficient for clinical handling. So I'm not sure whether we should use whole body MRI in all patients. We have been more practical, and so we recommend bone CT, and if the patient has pain, complaints of pain in part of the body where the CT does not show an abnormality, then we should make an MRI. If you cannot detect something on the MRI, then you should move to PET-CT. So it's more like an algorithm for using more complicated and more expensive techniques only when you really need them, rather than putting everyone in an MRI.
As a standard routine. That makes a lot of sense.
Yeah.
And do you do the GEP standardly, the gene expression profiling?
Well, this was partly developed in our laboratory here. So we have performed a lot of work in that area. We are trying to introduce the gene expression profile now in some clinical trials. It will also be used, maybe you know that, in Mayo Clinic to determine the gene expression-based risk group of patients. And one of our next trials in the European Myeloma Network will be based on gene expression profiling as a way to stratify high-risk versus standard-risk patients across the different treatments. This is a new technique, of course, and people need time to get used to it because they think that FISH you can do the same, but this is not really true because FISH only looks at predetermined abnormalities, a total of 5 or 6 in most trials, while gene expression profiling, of course, determines the risk group of a patient based on biology across all DNA data available.
And I have a question about the gene expression profile because you have expertise there. I think I had the 70 performed, and now I heard about an 80. Are those just testing for more genes, or how does that work?
Now, there are a number of signatures in the literature. There's a 70 gene-based and an 80 gene-based, both from Arkansas, from Little Rock, published by the group of Dr. Barnaby, and we developed a 92 gene-based of expression profile. And really the numbers don't matter. It's about what these genes come up as being most predictive for outcome in a group of patients that was uniformly treated. And this may be 17 or 70 or 80 or 92 or maybe 150 or maybe only 5. This is not, I mean, the number doesn't really matter. It's about how these genes come out of a statistical analysis performed on the whole 30,000 genes that can be detected on the gene expression platform. And maybe in ours it was 92 genes. Could be, if we analyze another set, that maybe 50 genes is also enough.
And now that you're doing the gene expression profiling and you have such detailed level of it, what are you seeing with the risk stratification? When I first started this series in July of last year, it was very, very early, and I would ask researchers, how is that changing treatment? And they said, well, pretty much quite not yet. But it seems like that's starting to change. What have you seen, and what are you doing with this extra information?
Well, what we observed in our analysis is that if you compare gene expression with FISH or ISS or combined analysis, gene expression always pops up as the most significant test for identifying the real high-risk patients. So this is the 10-15% worst prognosis patients. If you combine gene expression with ISS, so let's say biology with the clinic, this is especially statistically very powerful. So we think, and it's always better than FISH. So we think that FISH is in fact kind of a more simple analysis of the biology, just looking at some very common abnormalities, but it does not take into account all the different genes that are maybe involved in biology of myeloma. Gene expression looks at those genes and picks out the most influential ones. But gene expression by itself is also not enough. We should also look at mutations, as you probably know. So this is not yet finished. We are now looking, like others, to a combination of gene expression with SNP analysis, and also we look with newer techniques like the RNA sequencing technique as a next level of looking at the underlying biology of the individual patients.
Is that RNA sequencing the same thing as whole exome or the whole genome sequencing? Is that the same, or it's something completely different?
No, it's different. With RNA sequencing, you will look at RNA, so this is like with gene expression, also looks at RNA. But with RNA-seq is much more detailed. It doesn't just look at the expression of the gene, it also looks at the composition of the RNA that is expressed by the gene. And this is other than whole exome sequencing. With exome sequencing, you look at the DNA. And DNA is, of course, where the gene is. If the gene is translated into RNA, then you can detect it with RNA-seq. But if it is not translated, then you will only find it with exome sequencing. And exome sequencing can be done by looking at determined areas of the DNA, then we call it captured exome sequencing. For example, if you want to look at known abnormalities in myeloma, you can use that technique. Or whole exome sequencing, which means the whole of DNA is sequenced. And that's much more complex and time-consuming and expensive.
Mm-hmm. And then what do you do with that information?
Well, of course, we want to, a lot of things, but the two most important ones is to be able to identify patients that may respond to different treatments because they have the specific biologic abnormality that may respond best to, for example, bortezomib, or may respond best to another drug. That's one thing. And the other is that we want to get more insight, of course, in the biology of the myelomas. And one thing there is important, if the biology changes from diagnosis to relapse to second relapse and so on.
And are you changing therapies based on that information at the present, or is that still in the future?
Yeah, that's in the future. It's too early now. But this is clearly one thing where we want to go. And now the techniques become more standard and less expensive, so we can apply them to our large biobank from the clinical trials. It means that we can analyze hundreds of different myelomas. Hopefully this provides the information that we need. And in the next step, we probably, but maybe that's in 2 years or so, we will be able to run these sequencing techniques in every individual patient, then determine the risk class of those patients based on the biology, and then assign them to a certain treatment in a clinical trial.
Well, let's talk about your clinical trials for a minute. You mentioned the one with 1,500 patients. That's a stunning number of patients to aggregate for a trial. Can you describe what that trial was trying to determine and then what you found?
Well, this trial was about two questions. The first question is, do we need high-dose melphalan and stem cell transplantation at the time when we have all these novel agents available, so with proteasome inhibitors and lenalidomide? So we decided to randomize between high-dose melphalan in one arm and standard dose melphalan given as VNP in the other arm. And so this is one question. And the next question in the trial is whether it's really required to give consolidation and maintenance after the induction, or whether we should only give maintenance. So the second randomization is consolidation plus maintenance versus maintenance only. And these are the two questions that we want to address, and hopefully in a few years from now we will know the answer.
And this is an ongoing study. This is not a completed study yet, so it sounds like.
Yeah, the study is completed. Recruitment has been completed.
Oh, I see.
Recruitment was completed only a month ago, but of course many patients are still ongoing in the trial, so it takes probably 2 more years before we know the answer, when all the required number of events has been achieved.
And I noticed that in Europe, a lot of times prednisone is used over dexamethasone. Is there a reason for that?
Well, usually prednisone is used in combination with low-dose melphalan, like in the MP regimen, but only there. In all other drug combinations, people prefer to use dexamethasone, but in these times, primarily low-dose dexamethasone.
Okay.
So this is the 40 milligram per week maximum.
Because I had seen prednisone, and I don't typically see it in the United States, so I was just curious about that.
Yeah, that's because in the United States, the melphalan-prednisone regimen, which has been available since the 60s, is not used. People prefer Len-Dex or maybe Tal-Dex over the past years, or bortezomib-Dex. This is the standard combination in the United States, but not in Europe. In Europe, we prefer to give melphalan-prednisone plus another agent like Len or bortezomib or carfilzomib.
And you have access to all the new therapies, or is there is it something you get earlier or later than the U.S., or how does that work typically when new therapies come out?
Well, typically we get them later than the U.S. Is not typical for myeloma or hem-onc. Also for many other agents, that's the case. So, for example, in myeloma, we have now, of the novel agents, we have bortezomib, lenalidomide, and pomalidomide. And other agents like carfilzomib or ixazomib or what do you have are not, and elotuzumab are not yet available here, so they can only be used in the context of clinical trials. And maybe that's one of the positive arguments for patients to participate in clinical trials. They know that they get more easy access to novel agents.
Well, I'm a huge proponent of that because I think there are a lot of advantages to participating in clinical trials, and access to drugs is one of them. But being able to, collect your data first and know what you have, and then in the future, as things become available, be able to take advantage of that because you have more understanding about your disease biology. That's another. And then I think sometimes you get better care because you're being watched very carefully.
Absolutely. So, as you know, it has been shown that patients in clinical trials usually have better prognosis, better survival than patients outside clinical trials. But this may also be because there are selection criteria for clinical trials. So patients with significant comorbidities are usually excluded. So there are many reasons why the results in clinical trials are better. Yeah,
because it's difficult to test if you have a lot of other issues, right, to see if a treatment is going to work or not. Well, do you want to talk about other trials that you're working on? I saw that you had a phase 1/2 study using melphalan and something that I've never heard of before, flufenamide?
Yeah, that's called also melflufen. Melflufen is a prodrug of melphalan with less toxicity to the hematopoietic stem cells, and this has always been a major disadvantage of melphalan because if it harms stem cells, it might induce pancytopenia, but it has also been associated with a higher risk of secondary leukemias later on. So if you can develop, say, a variant of melphalan, which is as effective as melphalan for multiple myeloma, but less toxic to hematopoietic stem cells, that would be a major step forward. Melphalan is one of those drugs that we are doing clinical trials with, a phase 1, phase 2 study, by the way, together with some centers in the U.S., like Memorial Sloan in Boston. And the results are still in an early phase of development. But the results seem promising, so we will continue our trials with this drug.
It's fascinating that you can not only make things better, but determine completely new therapies through clinical trials. Do you have other studies that you'd like to share?
Yeah, well, one of the upcoming trials that will start early next year. There'll be a large prospective phase 3 trial of HOVON together with the French IFM group, again in the context of the European Myeloma Network, investigating the role of daratumumab, which is a monoclonal antibody against myeloma cells, together combined with chemo, the VTD regimen, in transplant-eligible patients. So in this trial, we will treat almost 1,100 patients, randomize them between standard chemo, high-dose melphalan, autologous transplant, standard consolidation, or the same regimen plus daratumumab during induction and consolidation, and then followed by a second randomization for maintenance with daratumumab or placebo. And this, we consider this as a major step in the future because it's a new approach using monoclonal antibody directed specifically against the myeloma cells. And this is a drug or an antibody, I should say, that has shown single agent activity which is significant in the relapsed refractory setting. So this will be the first trial in newly diagnosed patients, and then this will start early next year.
And it's newly diagnosed patients, not relapsed refractory. That's exciting.
Yeah, newly diagnosed, indeed.
And you said it's during induction and during consolidation. So in both,
correct. Yes.
Both areas. Okay, well, that's very exciting. The whole immunotherapy, I know patients are very excited about the whole immunotherapy use.
Yeah, we too, as a treating physician, because we have seen the success in lymphomas with rituximab. And then also results with elotuzumab in myeloma. But elotuzumab by itself is not very active. It needs to be combined. With daratumumab, we know that has also single-agent activity. So we are very interested in seeing if you combine this effective monoclonal antibody together with other effective agents like Velcade and thalidomide, whether we can really further increase the CR rate and hopefully also cure rate in myeloma.
And doing lots of these interviews, it's been interesting to figure out which one I would join upon relapse. And I think a daratumumab study would be one of my top priorities to look at and see if it would be the best, because it's a very exciting idea.
Yeah,
now,
I agree with you. Absolutely.
In some recent findings I saw that you had participated in, there was something called cereblon expression that was important for thalidomide and lenalidomide. Can you explain what that is or what you found?
Well, cereblon is a downstream molecule in the myeloma cell, which is important for the activity of IMiDs, so thalidomide and lenalidomide. This has not been a major subject of research in our group, but since we had gene expression data available for a large number of patients from our previous trial, we decided if cereblon level indeed is predictive for the outcome in patients that receive an IMiD. And indeed it was. So for patients with a higher cereblon level, the effect on progression-free survival was much more significant than in patients with a low cereblon level. So for effectivity of thalidomide, and this has also been shown for lenalidomide by other group in the US, you need cereblon in order the drug to be effective.
And what is that? Is that a gene? Is that I don't even know what that is. I'm sorry.
Yeah, it's a protein in the cell,
okay,
which is involved in with NF-kappa B metabolism. Well, this is biology, but it's just one protein coded by a gene, and normally it doesn't play a big role in the cell, but in myeloma it's upgraded in some patients and it's not in other patients. And it seems to be cereblon by itself, but also related proteins, seem to be the major target of IMiDs, thalidomide, lenalidomide, and probably also pomalidomide in the myeloma cell. If you don't have this protein in the myeloma cell, probably the IMiDs will be less effective.
Oh, well, that might be an important indicator. How do you test for that?
There's no routine test yet, so we got the data out of our gene expression database. But if you can also develop a specific PCR technique to look at it. One of the biological targets for the future to look at.
And I think new ones are happening all the time. And the better the testing, it seems that more things are being uncovered, which is very exciting. Even though it's some biology, it's important for patients to know that new indicators are being discovered. Yeah.
And I think one of the major conclusions over the past years has been that myeloma patients are not identical. So you need to know more about the biology of the underlying disease in order to make the right choices. That will be more and more important in the future.
And I saw that you had also done some work on autologous transplant versus allogeneic transplant. Would you like to share what you found there?
Well, that's correct. Over the past 10 years, we have put a lot of effort in trying to identify the role of allogeneic transplant. So this is a donor transplant in patients with myeloma, because we thought that, let's say, a graft versus myeloma effect would be important if we really wanted to cure patients. So over the years, we have treated quite a number of patients, at least 100 to 150, and compared the outcome of those patients with those in the trials that received only the autologous transplant. And unfortunately, allogeneic transplant has not been shown to be superior. Mm-hmm. So there are some patients that do very well and probably they may be cured, but toxicity of the regimen is too much. And many patients, between 25-30%, they do not survive the procedure. So this is why we at present have put allotransplant to a halt temporarily, and to see how we can improve the safety of this procedure while maintaining the effectivity in myeloma patients. And this is different from situation in acute myeloid leukemia, where we give allotransplant all the time, where the toxicity is less and the efficacy is very high.
That's very interesting.
Yeah. So for this time, no allotransplant, but with more sophisticated approaches to manipulate the graft versus host effect. Hopefully we can reintroduce it in the next years.
And I saw that one of the phase 3 study you were running had something to do with single versus tandem transplant also. Was that part of that study? Or
yeah, that's correct. I forgot to mention that. But in that 1,500 patient study, we also addressed the question whether a single or a tandem autologous transplant would be superior. So this is a sub-question in the trial. The health of the patients who were randomized for high-dose melphalan received one single high-dose melphalan, and the other half received a double autologous transplant. And this question was triggered by analysis of our previous trial, which indicated that a double autologous transplant might be superior to a single one.
Are those done more frequently in Europe? I know they're done at UAMS and at University of Iowa. Did that originate in Europe, or is that standard treatment in Europe, or how does that work?
You mean the double autologous transplant?
Uh-huh.
Yeah, okay. Well, this was not standard, both in the US and in Europe, but in some clinics in the Netherlands, also Italy, and especially Germany, patients were routinely treated with a double autologous transplant. I don't know how and where this started, but it has been clinical practice for the past 15 years or so in some of these countries, and people never addressed the question whether a single or a double tandem transplant would be better. There have been retrospective analyses. They never showed a difference. But now, when high-dose melphalan is used in the context also of the novel agents like bortezomib and thalidomide, it may be that a tandem autologous transplant has superior activity. We have to check that, and this is why it was one of the sub-questions in our EMN trial. But we don't know the result yet.
Right, and that'll still be the 2 years that you think.
Yes,
well,
at least 2 years. Yeah.
Can I ask you a little bit about smoldering myeloma and how you treat smoldering myeloma, or what you see on the horizon for smoldering myeloma?
You're aware, of course, of the Spanish trial that was published in the New England Journal by Dr. Mateos on smoldering myeloma. So up to now, we have not treated smoldering myeloma, at least not standard. But like in other trial groups, this time we are developing a randomized trial to see whether treatment of smoldering myeloma is useful anyway. So not only high-risk smoldering myeloma, but also standard-risk smoldering myeloma. Because if you look at the results of Dr. Mateos' trial, you will see that in the high-risk smoldering myeloma, even there patients are relapsing some within a relatively small follow-up, short follow-up. So we think that possibly in standard risk smoldering myeloma, there may also be a place for treatment. But this is a difficult question to address because many of these patients do not have complaints. They may have years ahead where they will not have complaints. So if you want to treat those patients, it's difficult to explain. And so we are working on a protocol, but we are not yet there.
Right. Yeah, I think that's the question worldwide, is how does that get treated?
It was really nice talking with you on these different issues. So
thank you so much, Dr. Sonneveld, for joining us today. I think your work with creating these amazing groups and compiling the number of patients that you are in these clinical trials is going to make a huge difference in patient care. So thank you for being so involved. Again, your resume is completely stunning. As patients, we're just so grateful that people like you are moving the bar forward.
Okay, well, we have to get somewhere, don't we?
Yes.
Thank you for your interest.
Well, thank you so much for participating.
Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.